So remember this week, we're having review sessions again because you've got another exam next week. And it will cover some of the concepts from the second exam, some of the high risk concepts that affect the newborn. And that's why they're on the third exam. So chorioamnionitis, why does it affect the newborn? Um, it's going to cover mainly the newborn, respiratory distress, meconium aspiration, neonatal abstinence syndrome, all those high risk aspects. What would you see? Make sure you understand those concepts. Review session today was at 1:30. Professor McGuffey, she's probably finishing up. I'll get that recording to you. As soon as the recordings are available, I'll post them in that announcement where it says exam 3 study session schedule. I'll post the recordings in there beside the instructor's schedule. There's one Wednesday morning. Thursday, there's one at 5 p.m. and Friday there are two. And then there's one Saturday morning at 10 o'clock in the morning. So they're kind of spread out a little bit throughout the week. So I really do encourage you to attend at least one live session and then watch the videos. Watch them for a while. You might not watch each one for a while. If you like what's going on in the review, in other words, you're finding it helpful, then watch the whole thing. If you don't like the style or it doesn't seem to be helpful, then don't watch it. Okay. There are some short videos associated with exam 3. They should be in the resources for exam 3. So check those out. They're helpful if you want more detail about each concept. Um, I need to add those to that announcement. I'm having my session Friday at 6. We'll probably do Jeopardy game again. If you want something different, we can add that to that time. Okay. I don't plan on doing a Sunday night unless I get a lot of demands for it, uh, like I did last week or last time. Um, if there's not a lot of people Friday night, I might have to, because I really need for a lot of students to do really well on exam 3. The goal is to get everybody to score in the 90s, because the better you do on exam 3, the better you are for your HESI. Okay, so that's what's going on this week. You also have another set of NCLEX questions this week. So what you're going to do, you're going to choose health problem again, and you're going to choose mother and newborn. So that'll include everything that's high risk. Do those, do 50 of them, and read through the rationales when you're finished. It's just a great study tool. Spend a good amount of time getting ready for this exam. Don't cheat yourself out. And then you have your CJ-SIM, you have another discussion question this week. You've got a lot of homework this week. If you have to choose homework to skip this week, skip the discussion. Okay, work on your NCLEX, spend a good deal of time on the NCLEX because you want to do well. Skip your discussion if you don't have time. If you want to, just do initial submission because it doesn't have that much value, and it's probably not going to help you that much on the exam. I say that lightly. Okay. In other words, it's not that I don't want you to do it. I want you to do your NCLEX though. Don't do your discussion if you've not done your NCLEX, especially if you've skipped an NCLEX before or you didn't do well on an NCLEX. NCLEX and CJ-SIMs are very important for you to finish and finish well. I'd rather you spend time going over your NCLEX and do extra NCLEX questions, extra CJ-SIMs than to do a discussion question. Um, if you want to go over your second exam with me, please do check with me, and we'll do that. If you want to stay after class tonight, I'll look at the exam and pick up those things that a lot of students didn't understand. Veal chop is still a challenge to you, and I know it's difficult. It's a difficult thing. Just remember, veal chop, don't forget that you need to turn off the oxytocin. Several of you missed and forgot to do that. You were good about repositioning and knowing that you needed to reposition, but you forgot to turn off your oxytocin. So don't forget about that. Just a lot. I know it's not easy. OB is not an easy course, especially when you're just learning about good perfusion and med surge and what it is. Uh, so that's this week. You're taking your last quiz today. Anybody have any questions before the quiz? I'm giving you a chance. Ask questions. Anybody want to ask me a question about high risk newborn? Breastfeeding too. We're talking about breastfeeding this week. What do you know about breastfeeding? What's important about it?
Immediately start it after birth.
Yeah, yeah. As soon as possible. Why is that? We talked about it last week.
The colostrum is what helps the baby have the first poop, right?
Yeah, yeah, colostrum. We'll talk about that a little bit today. Colostrum is call it liquid gold, right?
Yeah.
It's a laxative. Yes, it helps baby poop, get rid of some of that extra bilirubin they might have. Yes, yes. And the baby knows how to breastfeed because of what reflex?
Is it the suck or rooting reflex?
Rooting, sucking. Yeah, they have all those reflexes. So take advantage of that right away and get that baby breastfeeding, particularly which patients, which babies are you most concerned about that
Preterm
really
baby.
need to eat early?
Diabetic baby.
Mu Babies of diabetic mothers. Yes, yes, yes. Let's see. What else can I ask you? What is something you might notice in a newborn when you're doing the first APGAR that's common and not really normal, but common? Anybody know?
Is it the acrocyanosis?
Okay. What does that look like?
They'll have like blue hands and feet. And
Okay. So what is that from? Does anybody understand what that is? Acrocyanosis.
No, that is one of the terms I did not write down, but I was getting to.
What's cyanosis?
or
What would you see in a baby that's cyanotic?
They blue, aren't they?
They're kind of blue, yeah.
They have a lack of oxygen.
Yeah, lack of oxygen, poor saturation, that's severe. That's central cyanosis is when their mucous membranes are blue. Okay. Microcyanosis is not about oxygenation, is it? We're not really that concerned about it first 12 hours of their life, 24 hours. Kind of common. So what's going on when their hands and feet are blue?
is it just poor circulation?
Yeah, just poor circulation. So you could just rub their hands and feet, cover them and swaddle them up and massage their hands and feet to try to improve that circulation. It doesn't hurt anything. Just swaddle that baby. Okay. Let's see. What do you know about how do you know when a breastfed baby is getting enough to eat? How do you know when any baby's getting enough to eat?
By the number of diapers.
Yeah, 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 yeah. Are they urinating enough? So usually we want the first urination of a newborn to occur within the first 24 hours. We want to see wet diapers, a wet diaper within the first 24 hours. Now for those kidneys to kick in and begin functioning within 24 hours. Okay. All right. Those are some hints. Do you have any questions? Okay. Everybody have their canvas and ready to go? Sign on to Canvas and ready to go for your quiz?
Yes.
My computer's being slow. Give me just a second.
All right. Yes, you can use your calculator. You can use your computer for your calculator. You can use your phone for your calculator. You can use a piece of scrap paper and use your brain for a calculator.
I don't know if I trust that.
You don't know if you trust your brain?
Not with the math. I'm good with the calculator though.
All right.
I'm ready if you are.
You ready, Charles?
Yeah.
All right. Everybody else ready? Angelica, are you ready? She's feeding. All right. All right, everybody. So the access code is newborn, all lower cases, newborn. Newborn. Go ahead and get started. I hope I gave you some help.
Professor Zeller, can you check your DM?
Okay, let's get busy learning about the high risk newborn and review some of these things. So I think pretty much everything that was on the quiz we're talking about today. If not, by the end of the our time today, ask me if there's something we missed. Okay. So let's talk about, let's see. Right, everybody on camera. If you want to get off your extra device, now's the time to do it. Need to see your faces. So let's see. Rihanna, Angelica, Devonsha, Kenya, kind of hard to see. There you are. Don't want you falling asleep. Angelica, are you there? I don't see you. I see your shadow. There you are. Okay. So we're talking about the newborn today. What went wrong? So let's talk about birth injuries. Let's talk about the infant of the diabetic mother. Remember, we talked about the diabetic mother and her baby, the things that can occur during the pregnancy, during labor and delivery, and postpartum. Birth injuries, because we have a huge baby, macrosomia. This baby's at risk simply because it's a big baby. Because the big baby, with all that sugar during pregnancy, it did not allow for adequate surfactant to be produced. So the baby probably will have some respiratory distress. And then the risk for hypoglycemia. And we talked about how important it is for these babies to be fed within an hour or two right after delivery. So breastfeeding is ideal. But if mothers can't breastfeed or she's decided she doesn't want to breastfeed, then we have to help her choose a good commercial formula, which we can do that while she's in the hospital, but she needs to understand that she can't feed her baby cow's milk or goat milk. She needs to get formula, a good base formula. So let's go over each one of these things. So big babies, birth injuries. So I found some good videos, and you can take some time if you want to watch these videos. They kind of explain things pretty good details if you're interested about the brachial plexus injury. And I'll put that down for you, brachial plexus. And it shows really good pictures of the group of nerves in the neck that can be damaged, because when we deliver a baby, we're pulling up on the head and supporting it, especially after shoulder dystocia with a big baby. We might have a brachial plexus injury. It's a very good possibility that that might happen. So we might see Erb's palsy or Klumpke's palsy. And it just depends which part of those nerves, maybe both, were damaged. So if it was just C5 and C6 of nerves, then it's going to be Erb's palsy. If it was T6 and C7, it's going to be Klumpke's palsy. So you would know by watching the baby's movement or lack thereof. Okay. And so we're going to provide some kind of splint to support that joint in an abducted position because we don't want it to freeze on us. Baby will also go through physical therapy. So, and a good assessment of the newborn right after delivery. What do you think some things you might see if there was nerve damage? If it was a brachial plexus injury, nerve injury. What happens when the nerves are injured?
Maybe
What
pain.
happens? Maybe some pain. Okay. Baby might be a little fussy. Okay. What else?
The reflexes would be off and won't be able to move his arms.
Okay. Okay. So it depends which side. Sometimes it happens on both sides. That's pretty bad. Let's say unilaterally, one side. So in these two pictures, and this is part of a video. I just took the picture out of the video. So on the left side of this picture, this is Erb's palsy. So what you would see is the arm is extended and the hand and the arm are pronated. So, and it's not moving. So paralysis. So when you try to elicit the Moro reflex of a newborn, that startle reflex when they go like this, when they stick their arms out because they're startled, you're not going to see the arm that was with Erb's palsy. That arm is not going to do that. It's going to remain at the baby's side. So a missing Moro reflex. So you know that there was a brachial plexus injury if the Moro reflexes was, or if the Moro reflex is missing. Okay. With the Erb's palsy, you're gonna see, I'm sorry, with the Klumpke palsy, you're gonna see that the palmar reflex is missing. So you're right. You don't have to know the specifics between the two. But you know that if there was brachial plexus injury, you're going to see some missing reflexes. Okay, you might see a missing Moro or missing plantar reflexes, lack of movement, that sort of thing. What other things might you see with a birth injury besides a brachial plexus injury? What other injuries are there?
Like a clavicular fracture.
Clavicular fracture. FX means fracture. So if there's a broken clavicle from shoulder dystocia, what kinds of things would you see clinically?
Maybe lack of like muscle tone or something in that arm.
Well, maybe. You probably would still see some muscle tone, and you probably would maybe see some movement. It's not going to be paralyzed, is it? But you might not see as much movement because it's going to hurt, right? So you might have a limited movement. So there might be some reflex activity, but the baby's going to be crying. What else?
Will it be like swelling, maybe?
Okay, where the fractures, there might be some edema and swelling, collection of fluid there eventually. What else?
The moral reflexes will be off, right? or not.
Okay. Not as accentuated, right?
Yeah.
Okay. What else would you, if you palpate, what would you feel other than edema?
Lump or bump maybe.
Okay. Do you know what it feels like when you have a fracture? What it's called? Grinding. It's called a crepitus. It's a
Yeah.
grinding feeling. It's called crepitus. And so once again, we've got to support the joint. And it usually doesn't take very long to heal. It heals on its own as long as it's aligned correctly. So what we usually do in all these cases is get an x-ray to make sure we know what's going on. Anything else? And what other birth injuries are there? Had to cheat.
Do we use forceps anymore?
Yes, we'll talk about that in a minute. What's another injury?
Are they on the screen? Erb's palsy, Kappa-Succodium, or whatever, however you say it.
Okay.
I don't know
And
if
there's
I'm
also
right.
facial nerve palsy. And that's from the forceps, somebody already mentioned.
Is the cephalohematoma a birth injury?
Yes. Uh-huh. Mm-hmm. Okay.
One we
So let me
talked
get
about
down there.
today. Oh, sorry. One we talked about today was subgaleal hematoma.
Where'd you talk about that?
Today in SIM, we have SIM
Okay. Okay.
before
Okay.
class.
Okay. So let's talk about those. So cephalohematoma, it's a collection of blood between the periosteum and the skull. So it's going to be localized. It's going to be it's going to be over one bone section. Okay. So it's not going to cross over any bone suture lines, the division in the bone sections. You know, the suture lines are where the bones of the skull join. But in a newborn, they're not joined yet. Okay. There's still divisions because during labor, we need for those bones to kind of overlap. They need to be moldable during labor. Okay. So a cephalohematoma is in an area that's between the periosteum and the skull. So it's protected. It's not going to bleed across the suture lines. It's rarely a problem. Usually resolves on its own, but we do get x-rays just to make sure that it's nothing any deeper like a subgaleal, like you said. And it usually might show a little tiny hairline fracture. And we're going to monitor the baby just to make sure it continues to shrink on its own. Yes, they probably will have some bleeding and some increasing bilirubin levels, and they might become a little jaundiced, but it usually just resolves on its own. Now the parents are going to freak out. Okay, because there can be some pretty good sized hematomas, but we'll monitor and we can encourage them and explain to them. We usually rarely do we have to intervene with surgery or anything. So here's a picture on the left. This is I need to put this. This is on the wrong page. Sorry. This is a hematoma. See how it's localized in one area of the skull? And it's usually at the back. It's usually at the back. And it could be from forceps, just the trauma. It could also be from vacuum assisted deliveries. The caput, which I don't have a picture of right here, is just it's the molding of the head and its elongated shape of the head. This is above the periosteum. So this is just serosanguinous fluid from venous damage. So it does cross the suture line, but you're not going to get any elevated levels of hemoglobin. I'm sorry, of bilirubin. So it does cross the suture line. So you're not going to see jaundice. So it's very superficial and it usually spreads out. We usually don't have to do anything with caputs. Succedaneum, that's how you pronounce it. Succedaneum. And then the subgaleal hematomas. Here's a picture. A lot of times this is the vacuum assisted delivery. The subgaleal, we're more concerned about. It's a deeper bleed. And it's usually along the sides and the back. So they can lose a lot of blood because there's more vasculature in the deeper areas under the periosteum. So we have to closely watch their H&H levels. We have to monitor them for blood loss and low blood pressure. We're going to go ahead and type across them in case we have to give them some blood products. So you're going to feel a very boggy area and it's going to be very fluctuant. And you're going to see, clinically, you can see the discoloration. They don't have a lot of hair and the redness. You're not tested on the subgaleal. So our diabetic mothers and their babies, because of the high insulin levels in the babies, remember they have a lot of glucose in mother's blood. The glucose in mother's blood readily crosses into the fetal blood. So the fetus pancreas readily responds by providing more than enough insulin for the fetus. So they have high insulin levels during fetal life. And because of that, they're not able to produce adequate amount of surfactant during fetal life. So when they're born, they have very premature lungs, or their lungs don't have surfactant. So what would we see because they don't have enough surfactant? What would you see?
Respiratory distress.
Okay, respiratory distress. Do you remember what that looks like? What are the signs and symptoms?
Nasal flare,
Grunting,
rapid breathing,
retractions,
using accessory muscle, excessive crying, bluish of their mouth and their hands and feet.
Not acrocyanosis, not usually, just cyanosis. What's the respiratory rate, would you say?
Isn't it because they're like tachypneic?
Yeah. Okay. All right. So this is a great video. This is a video showing where'd it go? When I just found it this morning. This is a video showing how surfactant is administered. So they put it through the endotracheal tube. So this is a newborn that has insufficient surfactant. They have atelectasis. In other words, their alveoli has insufficient surfactants and their alveoli will not remain expanded. Okay, so we have to actually put surfactant in their trachea and instill it down into their lungs so it'll spread into the alveoli and allow the alveoli to expand. So if you take an x-ray, they're going to have widespread atelectasis, just like an adult would. Okay, so this video shows them moving a catheter down the endotracheal tube and then instilling the surfactant. And they might have to do that every couple hours to get those alveoli to expand and stay expanded. And that's how we manage these babies. It's not a very long video. It's only about 6.5 minutes. But it really does help you understand what's going on. So you can take a moment, a few minutes to watch it if you're interested. I just got it off of YouTube. I've never seen one until this morning. But that's surfactant that we would give to a newborn that had, infant of a diabetic mother because of respiratory distress. And hopefully, once we get that going and the baby is adjusting, then we can use positive pressure ventilation and extubate the baby. So you do need to understand and know the clinical signs of respiratory distress, again, for the next exam. Hypoglycemia in the baby. What would you see?
Irritability. They'll be very jittery.
Felicia, where are you? Oh, there you are. Okay. Okay. Angelica, I keep losing you. Are you there? Oh, okay. I just don't see you. You need to be in camera view. You need to be in camera view, Angelica. You're not in front of the camera. You're not supposed to be driving either. Are you driving? Angelica, are you driving? You're not supposed to be driving.
Okay.
Okay, you guys need to stay on camera, no driving. Okay, irritability, jittery. What else?
Weakness.
Hypotonic. That's for sure.
Lethargy,
Okay. Lethargy.
pale skin,
So what would you, what?
pale skin, rapid heart rate.
Okay, maybe some tachycardia.
They can have seizures if their blood glucose is too low.
That's true. So what would you do?
Feed
Check
them.
the blood.
Feed them.
Feed them, breastfeeding. So especially these diabetic babies. So we need to be feeding them how often?
Every 3 hours.
Actually, every 2 hours. Every 2 hours, ideally. every 2 hours. So when we're teaching about a mother that's breastfeeding, what things should they be avoiding?
Alcohol,
Smoking. Certain medications like pain medications.
What
like,
medications?
Like opioids.
or amphetamines.
That they can't eat certain foods.
Yeah, there might be some foods. It depends on the baby too. What else?
High amounts of caffeine.
Yeah. Yeah, reduce caffeine intake. HIV. Anybody with HIV, active, untreated, TB, herpes outbreak on the breast.
Fish or foods high in mercury.
Probably not a good idea for anybody. All right. Good. Neonatal abstinence. So if the mother is used to taking a very short acting drug up to the day she delivers, that baby's going to have symptoms of withdrawal in a short amount of time. So knowing her history when she's in labor, asking her about what she's been taking, when she took it, the last time she took it, then we can plan on when we expect the baby to experience withdrawals. And usually, nationwide, we usually keep our babies in the hospital at least 5 days after delivery so that we can catch any possible withdrawal symptoms. Nothing worse than letting a baby go home too early and then they begin withdrawals at home and there's no support or understanding of what to do. That's an awful situation. Neonatal abstinence syndrome, the babies have, trying to put this simply, their autonomic nervous system is dysregulated because of the effects of drugs. And it can be opioids, it can be amphetamines, it can be SSRIs. They go through withdrawals. So they're fragmented. They don't sleep well. They have trouble eating. They're uncoordinated. They have trouble sucking and swallowing. Their sleep is fragmented. They sneeze and they yawn for no reason. They sweat when a baby shouldn't be sweating. Vomiting, their GI system is messed up. Diarrhea, they're very difficult to console. Tremors, high-pitched cry. They're very rigid. And it's like they're very difficult to comfort because of the dysregulation. So number one guide is decreasing stimulation, because what's happening is that their dysregulation, their system does not know what to do with any incoming information. They don't know how to process it. So if we can reduce incoming information, reduce stimuli. That's less for them to have to process. So we keep the room dark, we keep it quiet, we keep the noise down, anything outside of the baby's system. Keep it dark, quiet, and no touching, less touching. Skin to skin, of course. Cluster care. Swaddling skin to skin provides external control to the baby. So it's eat and console the baby. So strategies for comfort. And so we're teaching mom these things, strategies for comfort. Review the abnormal findings in a male baby. What's a hydrocele? It's normal. It's not normal, but it's not that uncommon. It's harmless. We monitor. Sometimes we have to intervene. What do we do to assess it, to make sure there's no tumor there? How do we do that? Osmosis videos are good. There's a good one on hypospadias and epispadias as far as where is the urethral opening. That's part of the newborn assessment. What's the significance of it? If you have a male newborn with an epispadias or a hypospadias, what's the significance? Does anybody know?
Do you mean like they're not supposed to be circumcised? Is that what you mean?
Yes, exactly. Why do we not circumcise these males?
You need the foreskin to repair the.
Yeah, we use the foreskin, that extra skin, we use it to do the repair work. And so we can move the opening of the urethra to the end of the penis. Yes. Okay. So you need to know what those are. Okay, we're going to go over these last couple. Well, actually, let's go ahead and take a break and then we'll come back and finish these, okay? I don't want to rush through everything. We'll take a break for 15 minutes, okay? And we'll come back. You ready? So when you have a client in labor and she's having a very long, difficult labor, how do you know your fetus is in distress?
Look at their heart rate.
Okay, the fetal heart rate. What would it be if you were concerned? What would you be seeing?
It was elevated.
Okay, so fetal tachycardia greater than 160.
160.
What else?
You will see
Decelerations.
decelerations.
I'm sorry, what did you say?
Decelerations.
What kind of decelerations?
Late.
Late decelerations. Okay. Anything else? What other signs of distress are there?
The baby's gonna have the nasal flaring, the grunting.
We're talking about labor. We're talking about labor. During labor, what other signs of distress are there? There's a reason I'm going through all of this. Well, variable, right? Variable decelerations are another sign of fetal distress during labor. Prolonged decelerations. Minimal, sorry, variability in heart rate. Sinusoidal rhythm. A lot of different fetal heart patterns that tell us that the baby is having some distress. And if we're seeing these things, what could be occurring is hypoxemia, right? The baby's not getting adequate oxygenated blood. And with that reoccurring, hypoxia then is accumulating in the fetal tissues. And hypoxia in the fetal tissues causes relaxation of the rectal sphincter, which releases meconium. So we talked about this a little bit last week. So when there's meconium intrauterine, we call the help, because we're new nurses, we don't know what we're doing. So we're going to call somebody who knows what they're doing, calling NICU, respiratory therapy, calling our supervisor, calling the pediatrician, the neonatologist. We want to get some help because we're going to have a baby delivered in meconium. We see green amniotic fluid. So we have a baby born with green yellow staining of the umbilical cord. Nails are green. The skin has got green staining. The hair has got green staining. They have respiratory distress. They're showing signs of apnea, rhonchi in their chest, crepitation in their chest. So they've aspirated some meconium. It might not be real deep. It might be upper airway, and that's the safest way to have it, right? And we always do chest x-rays. We don't do vigorous suctioning. We want the baby to be able to move that stuff out of its own lungs and trachea. On the x-ray, you might see atelectasis, which is a deep alveolar collapse. They might develop pneumothorax. They might develop long-term meconium, and it might take a long time for them to get over it. There's a video here if you want to watch it about meconium aspiration. So what babies in particular are you thinking of that might experience meconium aspiration?
Maybe a baby past 40 weeks.
Okay. Okay, a big baby, post-term babies that are in labor a long time, labor dystocia, because they're big and they're not getting adequate oxygenation from an old placenta. Yes. Jaundice, yellow skin. So where do you see jaundice first? Where does it appear first?
Is it the forehead and eyes?
Yeah. So in the sclera, the eyes, the sclera aren't nice and white anymore. They're yellow tinged. What is jaundice?
It's a buildup of bilirubin in their body.
Bilirubin. So bilirubin comes from the breakdown of red blood cells. You know, our red blood cells only live about 120 days. And then they're normally broken down into different parts. And bilirubin is one of those parts. And the liver does that. The liver takes care of putting those parts where they belong. That's very simply put. Okay. It conjugates the bilirubin. The liver knows how to do that. It has an enzyme that it uses to take that bilirubin and connect it to a protein, and then we can just get rid of it through the feces. Well, our babies don't have mature livers, and so they really struggle with conjugating their bilirubin. So they kind of get behind. That's why they tend to get a little jaundiced. And there's different ways. There's physiologic jaundice, there's breastfeeding jaundice, and there's pathologic jaundice. Physiologic jaundice is just something we tend to see, and it usually occurs after the first 24 hours. You know, they just have excess jaundice. We just need to promote feeding. They just need to feed, feed, feed. Because the more they're eating, the more stools that they can pass. Breastfeeding is usually associated with not really getting enough to eat. If they're breastfeeding every 1 to 2 hours and they're latching well, then they're probably doing fine because breast milk helps to get rid of excess bilirubin. Pathologic jaundice, however, is not a good sign. You're going to see if you have a baby that's delivered and within 24 hours they're yellow. That's a pathologic jaundice. Has nothing to do with whether they're eating too little. It's not a physiologic, it's a pathologic. If it shows up early within those first 24 hours, if they're yellow. It's a blood or an Rh incompatibility. It means that something was occurring in utero. When the blood had an opportunity to mix, something occurred in utero, or she did not get RhoGAM the pregnancy prior. And we're going to go over that. So the way we treat bilirubin levels being too high, if we notice jaundice, is we promote feeding every 2 hours. And we can also use ultraviolet light. Ultraviolet light converts the unconjugated bilirubin, that circulating bilirubin that's not connected, that builds up in the tissue that causes jaundice. Ultraviolet light exposed to the skin will convert that to a soluble bilirubin, water soluble, so that it can pass through the feces. It doesn't have to be conjugated then. So we expose our babies to ultraviolet light long hours to help reduce bilirubin levels in the tissues and reduce the chance of the levels getting so high that causes brain damage. Hyperbilirubinemia, too high. So we talked about Rh negative mothers, and on their red blood cells, they don't have the Rh antigen. They're Rh negative. If the father is Rh positive, then there's a really good chance that baby's going to be Rh positive. And we make the assumption that the baby is positive. So at week 28, we're going to give mom some Rh RhoGAM. We're going to give her the actual RhoGAM, the immunoglobulin. to protect her, to prevent her body from making any antibodies. At the end of the pregnancy, when we know the blood is mixed, when she delivers her baby, we're going to give her RhoGAM again, and it prevents her body from making any antibodies against that Rh antigen that the baby has, so that when she gets pregnant the next time, that baby is protected. If we don't, then there will be antibodies in her blood that will attack her new baby and destroy the red blood cells. And then that new baby, her next pregnancy, that baby will become anemic. It could become severely anemic and will have jaundice within 24 hours of delivery, pathologic jaundice. It may be severe anemia and die. It's called hydrops fetalis. So we give RhoGAM to mothers that are negative if fathers are positive. Now, we do check the baby's blood when they're born. If the baby is Rh negative, then we don't need to give it. Necrotizing enterocolitis, when we have preterm babies, they're at risk for these two things. Preterm babies, because of their immature blood vessels. Their blood vessels are very fragile. They might not be completely formed. So in the eyes, retinopathy of prematurity is the exposure of the retinal blood vessels to higher levels of oxygen can damage the blood vessels of the retina and cause blindness. I think Stevie Wonder was blind because he experienced retinopathy of prematurity. So we give our newborns don't need high oxygenation. They just need low percentages, 32% is all they need. Low flow oxygen. They might need jet ventilation, CPAP, endotracheal tubes with 32% oxygen, not much higher than that. 100% for short periods, but not high pressure oxygen. It damages blood vessels. Because of their prematurity, their vessels are fragile. It can cause increased permeability. So we cover their eyes, because eyes, can absorb oxygen. And then necrotizing enterocolitis. The mesentery blood vessels might not be mature enough to be able to perfuse all of the intestines of a premature baby or even a full-term baby. So if the tissues of the intestines don't get perfused, they can die and begin to necrose. And if they necrose, then they become obstructed and they get infected. It's called NEC. Necrotizing enterocolitis. Now, these might be on the HESI. They're not on your next exam, but they might be on the HESI. Okay. Any questions about that? All right. I think what we're going to do, I want to talk about breastfeeding a little bit more because there are several questions on the next exam about breastfeeding. So let's go over the breastfeeding PowerPoint, okay? Even though that the PowerPoint I just showed you, I will post it for you so you can have it. But the breastfeeding one, I want to go over it. So do you remember the one question? I believe it was on the exam. Oh. What that's doing there. Oh. When's the best time to teach breastfeeding? Why is immediately after birth the best time to teach breastfeeding? I think we already talked about it.
Doesn't the baby need to eat because of the glucose levels?
Yeah, yeah, yeah. Usually we want the baby to eat right away. But the baby knows how to suck. And if you stimulate that rooting reflex, it's the best time we can teach mom about latching. The baby's ready to go. So it's a good time. The benefits of breastfeeding. Human milk provides the best nutrition. It establishes in that baby's gut the microflora, the natural bacteria that needs to be there. It establishes that microflora earlier than formula. It provides fatty acids for neurological development earlier and visual function. It has all the vitamins. Now, we do recommend that we supplement moms with vitamin D, 400 international units every day. Unless she is already taking it or she has a diet that contains adequate vitamin D. But just to make sure she's not low in vitamin D, we do recommend supplementing. Breast milk also has natural immunoglobulins, IgA, which helps fight bacterial infections. So it just sets up the newborn for fighting natural infections that they're in an environment and all the immunoglobulins that come along with it. But we don't want mothers who have HIV or Ebola virus. A newborn that has genetic metabolic abnormalities like galactosemia or maybe phenylalanine hydroxylase deficiency. We test for those two things in our screening of all newborns. So if it comes back that they're fine, then they can breastfeed. But until then, if there's any suspicion of family history of galactosemia or PhD, if mother has PhD, we're going to wait until feed formula until we get the results. Substance abuse. Unless mom we have proof that she's not on any opioids and she's on buprenorphine or methadone only, then we do not want her to breastfeed. If she's on buprenorphine or methadone, then yes, we do want her to breastfeed. But if she's using any kind of substance other than that, no. Herpes outbreak, no. And then untreated, and it's not on here. Untreated TB. Hepatitis B is safe because hepatitis B, there's no hepatitis B found in breast milk.
Excuse me? You said
Yes.
if your mom is taking methadone, she can breastfeed? You said that?
Yes,
Okay, okay. Got it,
methadone is very long-acting opioid agonist,
okay.
very long-acting, and minimal amounts are found in the breast milk. And if mom is on it, and the other benefit about methadone is that if mom is being compliant with the program, she is weaning, her baby's weaning. So as baby begins to wean off of breast milk, she's weaning off of the methadone. It's perfect in that situation. It gives, when a mother who's been on drugs feels a sense of success with breastfeeding and taking care of her own baby, feeling that sense of success does wonders for her own success. You see what I mean? It just supports her and it just gives her something to be proud of. So yes, definitely. Colostrum,
Is it-
liquid gold.
Sorry,
Go
is
ahead.
it for the mom to take methadone while she's pregnant?
Yes, yes,
Oh.
methadone or Subutex. Subutex is really preferred because it's a little safer. But if she's been on methadone and she wants to move to Subutex, perfect. But if she doesn't, then methadone, yes. Yeah. Colostrum. Colostrum is our liquid gold, the very first substance that the baby will receive if she's going to breastfeed. So colostrum actually is ready to go around week 16 of the pregnancy. The breasts are already capable of producing it. Colostrum is rich in antibodies, as we've talked about. It's a lot higher in protein than mature milk, but it's lower in fat. And the benefit of that is that that high level of protein in colostrum helps to bind that bilirubin, so that the mom who breastfeeds gets rid of that bilirubin faster. Colostrum is also a laxative, and hence babies that breastfeed are going to have liquid yellow stool. Seedy, they look seedy. Okay, so it helps pass that bilirubin early in postpartum. And then as the milk matures, it's less yellow and then becomes white, and it has higher levels of fat, which is what the baby needs as it's growing. As a baby breastfeeds longer, the rich milk comes later in the breast. That's why we promote breastfeeding one breast until it's almost empty, because it's towards the end of the milk of the breast, that the rich milk, and then finishing up the feeding with the other side. When she begins the next feeding, she starts with the second side and then finishes up on the original side. So she's alternating breast so that both breasts continue to produce milk. The stimulus for milk production are hormones from the pituitary gland in the brain. So when a baby sucks on the breast, that information, that stimulus goes to the brain, and it tells the pituitary gland, please produce prolactin and oxytocin, release it. So the pituitary gland sends that information to the breast. Prolactin tells the breast to make the milk. Oxytocin tells the breast to release the milk. So the more the baby sucks, the more milk that is produced and the more milk that is released. So it's a positive feedback system. The more the baby demands, the more often the baby breastfeeds, the more milk that's produced. So as the baby grows, the amount of milk grows. If she pumps between feedings, she's going to have more milk than what the baby needs. So she can freeze her milk. And there's just some signals or some cues of when a baby's hungry. The perfect latch. The reason we want the baby to latch on is so it makes breastfeeding more effective. In other words, you're not just sucking away at a nipple, you're grabbing around the ducts themselves. So the baby's not working as hard. You shouldn't see any dimpling of the cheeks. You should have audible swallowing. You should be able to hear the baby swallow. If mom chooses not to breastfeed, we want her to pick some kind of commercial off the shelf formula, okay? Any brand that she chooses, or whatever the pediatrician recommends. Not whole milk. And of course, fluoride supplementation is recommended according to where they live, the community they live in, and how the water supply is. And that the pediatrician in the local health department would be the source of information for that. It should have, the formula itself should have iron in it. Babies are also given vitamins. Okay, let's do this together. So you're the nurse and you're helping her with breastfeeding. And you're providing Nikki printed information and some websites that she can look at. And you're helping her with positioning and other things. So, education, what's effective? What's going to help her? Let's read the first one. Keep the baby wrapped in a blanket during feedings so she doesn't get cold. Is that going to help? Jessica is shaking her head no. Why not, Jessica?
I feel like they won't be able to get a proper latch if they're swaddled up in a blanket.
Okay. What's another reason?
Wouldn't it, if they were swaddled in a blanket, wouldn't it make it easier to move the baby around to get a proper latch?
Okay, yeah. Okay.
Skin to skin is better, so keep them unwrapped.
So why else don't we want to wrap that baby up?
Because it'll be asleep.
Yeah, we don't want them to be too comfortable when they fall asleep and they won't finish feeding. Right? Yeah, those are both good reasons. So some common positions are football, modified cradle, cross cradle, sideline. Yeah,
Effective.
yes. And I'm sure some women come up with their other styles. Should mom use the same position for every feeding?
No.
She probably would get sore. And to not be so stringent. Okay. How about maintaining the baby's body in alignment during latch and feeding?
Yes.
Yeah. So we want we're calling to be in alignment with the neck and the hips. We want the head up about 15 degrees higher than the hips and the stomach. Okay, we need to elevate a little bit. Okay, use the nipple to tickle the baby's lips, and when her mouth is open, lean forward to latch her onto the breast.
No.
Why not?
I'm just trying to figure out why are you leaning forward to even breastfeed?
Right, you want to bring the baby to the breast. Right, so you're moving the baby to the breast. So breaking the suction, if you have the baby breastfeeding and you're wanting to move the baby from one breast to the next one, one way of breaking the suction is by inserting a finger into the side of the baby's mouth to break the suction. Is that the way to do it?
Yes.
Yeah. Okay. All right. Signs of effective breastfeeding. So if the patient says her nipples are sore and you're looking and they look red, and you also notice that the baby doesn't seem to be voiding as often as the baby should be, and maybe hasn't passed a stool for a while, and you're wondering, oh, maybe the baby's not getting enough, and maybe there's a problem with the baby latching. So let's choose. What are some signs of effective breastfeeding? A. So these are select all that apply. Because, A would be, so each one of these we're asking ourselves, true or false?
D and E and F.
Is it
What
B
else?
as well?
Which one?
D
B?
as in dog. Oh,
I said,
Yep.
Oh, I'm sorry. I thought it said ineffective breastfeeding.
No. What are the signs of effective breastfeeding?
and then A.
Yeah, we don't want babies sucks with cheeks dimpled. So breastfed babies might lose 5 to 7% of their body weight during that first week. All babies might lose some weight that first week. So signs of effective breastfeeding then would be for the mother, copious milk production by day 3, firm tugging feeling, but no pain. After pains, in other words, the uterus is contracting during breastfeeding because of the oxytocin released. The breast soften as the baby is finishing that breastfeeding on one breast. Newborn latches without difficulty, audible swallowing, easily releases the breast after feeding, 6 to 8 wet diapers a day, and 3 to 4 bowel movements daily or more. Those yellow, sticky, seedy bowel movements. breast milk jaundice, also known as lack of breast milk jaundice. So usually they're breastfeeding every couple hours to 3 hours a day during the first several days of life. And we want that because we want that bilirubin to be under control. And we want the baby to get adequate amount of fluids. So we can visualize any jaundice. We can look at the eyes. We can also take a thumb and press on the forehead of the baby and blanch it, and it should turn a yellow color if the bilirubin levels are high or if they're elevated. Let me put it that way. If they're elevated, we should be able to see that. And then we can do a transcutaneous check with our monitor. And if there's any question at all, we can draw some blood. And that's why we're in the hospital. Well, the baby's in the hospital. And then sometimes if we have a baby with a high level and we have educated mom and we feel like they're going to be compliant and baby safe enough to go home, what we'll do is we'll have them come back to the doctor's office, pediatric office, in a few days, and we'll check again, checking the Billy levels and to make sure everything is going well. So, breast milk is really promoted in preterm babies, especially because it helps with maturation of the retinal vessels and neurocognitive development. It's with research, it has shown us that it really enhances and protects the brain and the eyes. It helps to decrease the risk for sepsis because of the natural antibodies in the breast milk. It diminishes the risk also for necrotizing enterocolitis, urinary tract infections, and upper respiratory infections. So even if mom doesn't want to breastfeed, we can use donor milk, or there might be another woman not be willing to pump milk and donate. Let's see. Okay. So just some things, the CDC has guidelines as far as if a mother is pumping milk, how to store it, how long she can freeze it, how long she can keep it in the microwave, how to reheat it. We never reheat in a microwave oven. It can damage the quality of the milk, and it's an uneven heating. So just running it under hot water, or sitting in a double boiler on a stove is the best way to do it. So the CDC has guidelines. And then taking care of how to clean a breast pump, when to pump and dump, things like that. Or there is no standard care of pumping and dumping. It's up to the mother, the baby, and the pediatrician. We teach mom about her own caloric needs. When she's breastfeeding, she's going to need more calories during the day. She has to eat before she breastfeeds. She can't expect her breast to make milk if she's not eating. She needs more fluids. She needs to keep her breast clean. Just warm water over her breast, no creams, lotions, and soap. That's just going to harbor bacteria, and we want her nipples to toughen up. If she's on antibiotics, it might cause thrush or fungal infections in the newborn's palate or on the tongue, those are easily treated. Alcohol and caffeine can pass through the milk and reduce milk production in mother. So we encourage her to avoid those things. Mastitis. Mastitis doesn't necessarily have to be in a woman. It's not necessarily only found in women who are breastfeeding. It could be caused by any kind of surface bacteria, even in non-breastfeeding women. So how we manage mastitis? Warm, moist compresses so that we can get rid of any engorgement. Continue to breastfeed. Or at least keep the breast empty. Ibuprofen is safe, even with breastfeeding. Cold compresses can be used between feedings for comfort, and it helps decrease inflammation. Antibiotics are used if necessary. A lot of times it's just inflammation. If it develops into an abscess or some kind of cellulitis, then we certainly don't want her to breastfeed if that's what's going on. But that's up to the pediatrician or up to her obstetrician. If she develops a fever, malaise, and serious erythema, then she does need to be seen. Okay. Any questions? No? Okay. A lot of information. All right. So what do you want to do now with our time?
I did have a quick question about the Rogam shot. Rogam.
Okay.
Do they give that shot on like subsequent pregnancies and not the first one, or is it every pregnancy?
Every pregnancy, because it's only good for 12 weeks.
Okay.
Yeah. And also, if we have a pregnant woman and she's Rh negative, if she has a miscarriage, we give it then. Because if she's carrying a embryo or a fetus and has a miscarriage, and that embryo or fetus has a blood type with an Rh antigen, and she miscarriages, there's mixing of blood. Her body is exposed to that Rh antigen. It's an antigen. It's a foreign object. It's a foreign substance. Her body doesn't recognize it. So she will make antibodies against it. And it'll stay in her system. So when she gets pregnant again, if her next embryo or fetus has Rh antigen on its red blood cells, she already has the antibodies in her system. And those antibodies will begin to destroy that new baby's red blood cells. Does that make sense? So every time she gets pregnant, the Rogam only lasts for 12 weeks. So every time she gets pregnant, we need to give it to her because it prevents her from making it. We give her a temporary dose of the immunoglobulin.
I also have a question. You said that it was okay to breastfeed, or don't breastfeed if the mom has untreated TB, but if she has Hep B, it is okay to breastfeed, right?
If she what?
Has Hep B, hepatitis B, you said it was okay?
Yes, yeah, because it's not found in breast milk.
Okay. Okay, just making sure.
Yeah. But not HIV, because it's found in breast milk. Now, I've had HIV patients breastfeed. Their viral load was super, super low, undetectable, and they wanted to breastfeed. I didn't really want them to, but they were determined. So they did. But not normally. It's not recommended. Anything else? Okay. So, what's APGAR measuring?
You said what's APGAR measuring?
Mm-hmm.
Oh, that is the score to see whether the baby is healthy when it's first born and then 5 minutes after birth.
Okay, okay. So what's the A stand for?
Appearance.
Appearance,
Appearance.
And what's the P stand for?
pulse,
What's the G stand for?
grimace,
And what's the second A stand for?
activity, and then
Activity.
respiration.
And respirations. Good. Now you'll be glad to know you're not going to have to do an APGAR on the exam.
Good.
Yay. Let's see here. Let me look at the quiz. Let's see what real quick. In case we missed something on the quiz. So acrocyanosis was on there. Breastfeeding effectiveness, 6 to 10 diapers, wet diapers, 6 to 7, 6 to 8 wet diapers a day. What's the very first thing you do with a baby that's just delivered? What's the most important thing that you need to do?
Check his blood sugar.
Skin
know.
to skin.
Skin to skin. Yeah.
Dry it off.
ABCs.
Dry that baby. Dry that baby off. Dry that baby, stimulate that baby, remove those wet blankets, skin to skin. After a minute, you do an APGAR. You got to wait a minute. So there's a lot to get done in that first minute, right? Get the baby dried off. Why is breast milk better than formula?
To promote natural flora in the stomach.
Natural flora.
You get those
What else?
globulins from the I can't say that word. Immunoglobulins from the colostrum.
That's right. Immunoglobulins. Yeah, those natural antibodies. That's right. IgA. How are some ways that we can comfort a baby going through neonatal abstinence syndrome?
You can
Dim the lights.
Dim the lights.
you can swaddle them.
Swaddle the baby. So you're providing an external control. You know, and this might not be, I think it's a good illustration. If you have a dog that hates storms, you know, any of you familiar with thunder jackets for dogs? Yeah, I have a dog, she's a Great Pyrenees. I have 2 of them. And I have one that's just scared to death of hot air balloons. If I put a blanket on her back, just cover her back, she relaxes. It's the same idea that you're containing around the outside and holding on to them. It's like external comfort or something.
She's scared
Same
of hot air
thing.
balloons.
Yeah.
How
The reason
often are you around hot air balloons?
every fall, because right down about 1.5 miles from our house, that's where they take off. And when they go up, they go over our house. So they're only probably about 150 feet the most when they go over our house, and they open up the vent and go,
What state do you live in?
Michigan.
Oh, okay. I was wondering, 'cause when I was in the military, we used to go, I did some training over in Elizabeth Island, North Carolina, and that's where they do like the blimp and stuff, the Goodyear blimp, and they were all over
Yeah.
the place out there. That was pretty cool. I didn't know if you lived
Yeah,
close
and
to that.
it's real loud. I mean, they're like right up there, and it's loud. And they open up the gas, and a fire goes, and it scared her to death. Now every time she goes outside, she looks up first. You know, it's so sad. She was so traumatized. Anyway, putting a towel over her and just like swaddling a newborn, it just comforts them. Okay. So a macrostomic baby, over 4,000 grams, 4 kilograms. They're going to be at risk for clavicle fracture, humeral fracture, shoulder dystocia, of course, hypoglycemia, respiratory distress. If they're a baby of a diabetic mother, if they're just large for gestational age, they still could be at risk for the same thing, but not hypobilirubinemia. Make sure you're reading those choices. Hypobilirubinemia, no. And not necrotizing enterocolitis, not retinopathy. Those are preterm babies. Let's see. APGAR. So we do it at 1 minute and at 5 minutes. And then with the math, one outcome of skin to skin is what?
Warm.
Thermostability.
Warmth. Thermostability. What else?
Bonding.
Bonding. That baby's on that mother's chest. What else? What are some other benefits of putting that baby on that mother's chest?
It can regulate their heart rate with the mom.
Okay, that's called cardiopulmonary stability. And then one more.
Body
What?
body heat. The temperature for the baby.
We said that. Thermostability.
Breastfeeding.
Breastfeeding. There's videos on YouTube where they put a baby on mom's belly and the baby actually crawls up to the breast. Just like a cat or a dog would.
They did this when my wife had our last daughter. She was in surgery for a while, so she wasn't around to do it. So they made me do the kangaroo thing.
Oh,
Pretty
yeah.
cool.
Yeah. So which one would you suspect would develop a hematoma? A caput succedia or a cephalohematoma?
This cephalhematoma.
Cephalohematoma. Mhm. So higher bilirubin, so you're going to see jaundice. Yep. Okay. All right. So let me look at what else we can talk about. So there's also sexually transmitted diseases that mom can contract during pregnancy, called torch infections. And there's some other ones, the group beta strep and syphilis, gonorrhea, chlamydia. you're not gonna have to know these, for, the exams in this class. I don't know if you'll have to know 'em for the HESI or not, but we do test for HIV, during, at the very first visit, and we do, check for group beta strep. We do the culture at the beginning, or at the end of the pregnancy. If we haven't found group beta strep, we do the perineal and, vaginal and rectal cultures. When we begin to check for cervical dilation in the office, we'll check to see if they do carry group beta strep. Because that can cause chorioamnionitis. It can also cause pneumonia, and meningitis. So we do culture for that. So if they are positive for that, then we treat them with antibiotics during labor. Syphilis, if it's positive, we treat them right away with, intramuscular penicillin. Chlamydia, we watch during pregnancy and treat them accordingly. Same with gonorrhea and trichomoniasis. And then the torch themselves, toxoplasmosis, parvo, cytomegalovirus, those things, all kind of present as, if the babies are exposed to those during pregnancies, they present almost kind of similar rashes, after they're born. You don't have to know those specifically. I don't know them. They're not very common, and most NICU nurses probably wouldn't recognize some of them. Now, herpes, but if a baby presents with an unusual rash, they're going to be, isolated until we figure out what it is. Now, do you remember erythema toxicum? It's a harmless rash all over the baby. And it's not anything to be concerned about. It's not contagious. It doesn't cause any discomfort to the baby. It's normal. And it'll go away on its own. That's the erythema toxicum. Let's see. What else? Herpes, definitely very serious. Zika virus, very serious. Sometimes you'll see babies with Zika and parvo. They'll be born if they're in cytomegalovirus. If they were exposed during the pregnancy, they will have, what's it called? A smaller head, microencephaly, a smaller head, and probably some neurological deficiencies. Rubella, that will definitely be on the HESI. Understanding exposure. If mother is not immune during the pregnancy and she's exposed, heart damage, I think, hearing loss are the two biggies. That's the big, but you're not going to have any questions on the exam, not on the third exam about any of these. But I'm pretty sure. Yeah. It's just a lot to take in. But you a baby that's sick, a sick baby, an evolving infection is going to present almost similar to a baby with hypoglycemia. Or, it's or respiratory distress. Lethargy, not interested in feeding. It's like they present with the same symptoms. So checking glucose and feeding them is what we do initially, and supporting their systems. Let's see what else. Usually don't have this much time. But it's okay. Let's see. See if there's anything missed. I'm just going back to my original PowerPoint. Oh, fetal alcohol syndrome. What do you know about fetal alcohol syndrome? How much alcohol does it take to cause damage? We don't know. So we advise no alcohol during pregnancy. No, because we don't know when the damage would occur. But a lot of times it's permanent, of course. And what we typically see is low birth weight babies, emotional labile. In other words, emotional immaturity, emotionally and intellectual immaturity, cognitive impairment. I can tell you of a story of one of my patients. She was in her upper 20s, and she herself had fetal alcohol syndrome. And I was guessing that she probably had the emotional age of maybe a 10-year-old. And she became pregnant. She wasn't married. She became pregnant herself. And that was a real challenge to take her through her pregnancy at that emotional age. Maybe even less than a 10-year-old nowadays. 10 years old, 10-year-old girls are pretty advanced. But she was, I mean, every little thing. But when after she had her baby, she was a really good mother. And then her boyfriend left her, and it was a disaster because she didn't have a whole lot of family support. But she was a good mother. I had to explain and work with her a lot. She needed a lot of support, social support, but she was very emotionally immature. She understood a lot when you taught her, but emotionally, she was very difficult to work with. So they have a lot of faces, you might say, that are not always recognizable at birth, like a Down syndrome baby would be. And fetal alcohol is not it's not a genetic disorder like or a chromosomal disorder like Down syndrome is. So it's on a continuum. Depends how much alcohol, probably. And so they might be very intelligent or real severely retarded. So it just kind of depends where they are. So you might not see it so obviously in their face, but sometimes, they have a very flat philtrum here and a flat face, narrow eyes are small, and sometimes low set ears. So just looking at them, you might not be able to tell. Let's see what else. So nicotine, it's your ABO incompatibilities. We talked about that. I think we about have everything. Okay. I guess I can just let you go early today. The PowerPoint for exam 3, I'm going to go ahead and put that in with the exam 3 schedule for the review sessions, and I'll add in those short recordings. Okay. So you'll have that for exam 3. Please go to review sessions this week for exam 3. And if you need one-on-one with me to go over some things, You can do that. You can also get on to your NCLEX and do some of the NGN style questions. You can look at the HESI book, the HESI Next Gen book, to get some questions out of there to practice. So there's more than enough resources for you as well. Okay? We're early, so we're not supposed to finish until 5:15. You got 15 minutes.
So for exam 3, do you recommend us going back looking at the videos for week 6?
Week 7. Yeah, look, DVTs, look at DVTs, look at the bleeding stuff. DVT. All those things will be on, we're doing Jeopardy. I'll post my Jeopardy link too. Need to make myself a note, okay? Bye, Judy. Bye.